Our objectives for the time that we have together this afternoon is to reflect on the work to date and envision next steps to enhance school-linked behavioral health services, to empower community voices, engage in activities to foster collaboration and learning, and to provide insight on technical assistance and ways to improve administration of the capacity grants. So we've just completed our welcome, but later on we'll move into our inclusive welcome, and that will be followed by our peer learning and discussion. Next slide, please. So a few housekeeping items before we proceed. If you have not already done so, please indicate your COE next to your name. And just FYI, today's community of practice is being recorded. And after the meeting today, the recording and slides will be posted on the Capacity Grant website. So that brings us to the end of my portion of today's welcome. And so I'm passing the mic to my colleague, Mary Reed, for our inclusive welcome.
All right, good afternoon, everyone. Really excited to be with you here this afternoon, and very grateful for the opportunity to blend social emotional learning in with the capacity grants work. If you're new to the 3 signature practices of social emotional learning, they're really a great way to be intentional about weaving SEL into our adult learning opportunities, trainings, meetings, etc. And we're going to start out with an inclusive welcome from our partners at San Diego County Office of Ed. They are going to be our spotlight next month for October. So we invited them here today to share an inclusive welcome and just bring this learning to our community of practice today. So I'm going to pass it off to Heather and Leslie from San Diego County Office of Ed for our inclusive welcome. Thank you very much.
Okay, thank you, Mary. Appreciate it. Hello, everyone. Good to see all our sister COEs. So we wanted to share a welcoming activity that we have done in our county as we embed welcoming activities in our meetings. And this one has been one of the most popular ones. And so we are entering the fall season. And with that comes cooler weather. And with that comes baking and being able to make all of our Halloween and holiday different baked goods. So it felt like a good time to do this activity. And so we're going to learn about cookies, and we're going to learn about how it connects to our own personalities. And cookies in general make us feel warm, they make us happy, and they're a great way to connect with each other, even when especially when it's with a coffee. So we're going to do a fun light activity, and you're already doing it. Look at the cookies and which one below is your cookie of choice. So I see Leslie's going to help me gauge the chat and kind of read out identifying some high trends. Got a lot of letters, Leslie, help me out. Chocolate chip, sugar, macaroons, peanut butter, or snickerdoodle.
And we have some folks who can't choose between one, which is awesome. So Bethany is chocolate chip and snickerdoodle. Leslie from Laco is sugar and snickerdoodle. Ooh, Liz with 4 or 5 exclamation points, chocolate chip. We have Mary from Oh, thank you, DHCS, who is chocolate chip and peanut butter. And Eli from Nevada County, number 5 is the best. So that would be a snickerdoodle. Wow, look at all this contribution in the chat.
I think
Cookies
there's a
are getting
lot
everyone
of
excited.
chocolate chip seems to be the winning trending cookie out there.
Yes,
Followed by
Oh,
I
look
don't
at
know,
Amar,
maybe
though.
macaron.
Look at Amar from
Snickerdoodles.
DHCS. He's E, like many, 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 many E's.
Pumpkin chocolate chip. Oh, that's a good one. Great. All right, so we have a lot in common with these cookies, especially with the chocolate chip. Okay, so thank you for that. Now we are going to find out, what does this mean? What does it reveal about your personality? And totally legit and science-based quiz here. So the next slide is going to show you the personality that matches with the cookie, and we want to know if it's accurate or not. So if you could share in the chat, yes, that's me. No, that's not me. The other cookie's more me. We're just curious if this is really scientifically validated. So chocolate chip, you're kind, reliable, well-liked, you like routine. Sugar, you're honest, genuine, adaptable. You are both simple and sophisticated. Macaroons, you are sophisticated, stylish, unique, and expressive. Peanut butter, you're deep, thoughtful, and have a clever sense of humor. And snickerdoodle, you are interesting, funny, social, and energetic. Such great qualities come along with each of them. So what do we got, Leslie?
It looks like a lot of people feel that this is very legitimate and it's reflective of their personalities. Let's see, Corrine, 100%. I almost put B in addition to E would have been even more on point. All right, Corrine. Maritza from VCOE, 100% accurate for both of my choices. Oh, David wants, yes, David, we could totally bill on behalf of all of you all. Oh, Liz, you can't leave us hanging. I want to think I'm a peanut butter, but let's be honest here. Was it chocolate chip for you, Liz?
Yeah.
And did we see Amar? Amar, does Snickerdoodle match? I want to say just from all the meetings I've observed you in, I would say a yes, but I don't know if you chimed in the chat if you thought it.
Wow. It's feeling like everybody's feeling like this is accurate. So it must be scientifically validated. I'm Snickerdoodle, and I think I'm funny and kind of interesting. And I'm very social, and I'm very energetic. So it definitely matches me. But I think I'm funny. So there's that. All right.
Rhonda,
Okay, yeah,
let's
we
see,
do.
macaroons.
David says
I
we
would-
need some milk now. That's very true. So
Rhonda,
no.
yes, yes, we would say sophisticated, unique, and expressive.
Nice. All right.
Well,
Well,
thanks,
thank you for
everyone.
participating in that and having a little fun with us. And we look forward to presenting next month. So thank you, Mary.
Yeah, wonderful. Thank you, ladies, so much. That was definitely a fun way to start out our meeting. And I'm sure a lot of us are maybe planning some baking, maybe for this evening or this weekend. And with that, I'm going to pass it over to Patrick, who's going to get us kicked off on our spotlight, peer learning.
All right. Thank you, Mary, and thank you, Heather and Leslie. That was phenomenal. I am so hungry right now. I absolutely am going to be baking cookies tonight with my kids. I'm not sure which one of my kids would be, actually. I'll have to ask my wife which she thinks my kids would be. My name is Patrick Shermer. I'm over here with SCOE's Capacity Grant team. And just as a reminder, I'm actually coming most recently from Sacramento's school-based mental health and wellness program. I deeply believe in the transformational power of school-based mental health, and I'm so excited to get to support all of you in rolling out this game-changing work. I've been doing school-based therapy for about 12 years, and I saw over and over and over again how providing mental health services in the school setting can truly support mental health and wellness in an embedded and community-centric way. This just isn't possible in the same way in a clinic or private practice setting. And something that I feel like the field of mental health is learning again and again in recent years is that mental health and wellness is community wellness. And I feel like that perfectly is just the great handoff into the vision of FQHCs and what Alameda has been doing for a while now. Yeah, so just to kind of quickly go over the flow of today's peer learning session, we're fully in the peer learning portion of our community practice. First, we will have our spotlight from Alameda, and then after the spotlight, we will have a break. And then when we return from break, we will have our peer learning discussion and share out. And then there'll be time to complete the feedback form. So we'll do some like breakout rooms after the break and supporting everyone in peer learning. And finally, we'll end the community practice with an intentional closure. So for our focus today around federally qualified health centers, I'm so excited to present and introduce all of you to Alameda. It's been so great kind of planning with them and getting to know Kate and Kale. They're doing phenomenal work down in Alameda. the partnerships with FQHCs and behavioral health CBOs to create 28 school health centers in the county. It's just powerful work that is shifting, I truly believe, the mental health and wellness of entire communities in their county. And they've been doing this for a long, long time. I believe they began this work back in 1989 and have been expanding and deepening it ever since then. But they'll be the first to tell you that even though they've been doing this work for a long time, they're still iterating, they're still learning, they're still shifting this work we do, especially in the sea of reforms that are happening from the federal and state level around funding for mental health services. And I just want to plug, we sent out in our program update on our online community last week, we attached a report that WestEd did around how the fee schedule intersects with this work that Alameda County is doing. The report is really phenomenal. I actually had a lot of fun reading it. And there's also a slide deck as well that is in that online community post if you don't have time to read the full report. But definitely really encourage you to go check that out if you're finding yourself really interested in this. So without further ado, I would like to hand it off to Kate.
Hello, everyone. And yeah, it's so nice to be with you all. I am Kate Graves. I work for Alameda County Health. This is something that happens, and when I was working with school districts really closely, we would always say we were trying to pass as County Office of Ed employees, but in fact, we are Alameda County Health Department. So that is who we are. And we are, within the health department, we are Alameda County Healthy Schools and Communities. And we're really excited and honored to be with you all today. I noticed in the chat a lot of people that I've seen in various places, some people that we've worked really closely with. So again, an honor to be able to share our work. And we're specifically talking about the school health center model, which are partnerships with the federally qualified health centers and other lead agencies. So Kale Jenks, who's the coordinator of our school health center work, and Lisa Erickson, who's the director, are also on the call with us today. So we will be continuing through, and again, really excited to be here with you all. Yeah, you can go to the next slide. So Alameda County is a county of about a bit more than 1.5 million folks, 1.65 million. And we have 14 cities and 6 unincorporated areas, 19 school districts, and folks from all over the world, really, and are really excited to be doing this work and have been doing this work for some time. The way that we do this work within the partnerships is really within Healthy Schools and Communities. So we are a small department within the larger healthcare services agency that has behavioral health, public health, environmental health, housing and services for housing and unhoused folks. Sorry, housing services. We basically, Healthy Schools and Communities focuses on these strategies with children, youth, and their families at the center. So we focus on systems building with schools and communities. We focus on family engagement and support, and we focus on youth wellness and leadership. So this looks like a lot of different things. This looks like folks who are at individual school sites, folks who are embedded at the district level to provide support on infrastructure building, like coordination of services teams, which is something that we've been building and supporting and providing TA on for quite some time. Those are some of the systems building strategies. Family engagement and support, and youth wellness and leadership. All of our work is done with a health equity lens. So where we do our work is heavily impacted by who lives in specific communities. And we definitely have more services in communities that have lower health and education outcomes. That is a driving force of where we do our work. We really want to represent and support underserved populations across the county. Okay, last of my slides. And why is the county health department so embedded in the schools? Because health and education are linked. You all know this better than anyone. I won't say much more than that. So healthy students learn better, education contributes to longer and healthier lives. And by collaborating across sectors, we can really reduce the inequities in our communities. That's what we believe, and that's what our work is about, and we believe that work is more important now than ever. And the last thing I'll say before I hand it over to Kale is that we've done this blending and braiding work for for a very long time. And in specifically related to school health centers, it's been well over a decade of doing this work. So what you're seeing is that long-term effect of blending and braiding resources and collaborating across systems. So I'll stop there and hand it over to Cam. Thanks again for having us.
All right, thank you, Kate. Once again, my name is Kale Jenks. I'm the School Health Center Coordinator. And over the next few slides, I'm going to talk a little bit about our model and services in Alameda County. So school health centers are health clinics located on or directly near a school focused on providing age-appropriate services to children and youth. These clinical spaces remove the barrier of transportation and empower youth to develop trusting relationships with healthcare providers. They are open throughout the school year and in most cases through the summer. So school health centers and wellness centers are sometimes used interchangeably. And for our purposes of presenting today, school health centers must provide medical services, whereas wellness centers do not. This is aligned with the definition used by the California School-Based Health Alliance, the statewide organization supporting LEAs and healthcare partners in school health. And if any of you are interested in learning more about school health centers after this presentation, in addition to reaching out to myself or Kate, I highly suggest that you take a look at CSHA's website. And they host regional coalitions that include LEA and health partners to support the work. So Kate shared, so how did we get here? So in the early 90s in Alameda County, there were 6 school health centers that were operated by 5 different organizations in 5 different school districts. ACE Health saw the importance and the impact of school health centers and the opportunity to support their individual efforts. And so in 1996, ACE Health established the School Health Center Coalition with a focus on really helping them align services across the agencies, as well as support the relationships with the districts and the school sites. And over time, that work led to establishing the School Health Center Coordinator position, which I hold, and our efforts continue to increase by providing funding, technical assistance to both the school health center providers and the districts in site, as well as hosting a monthly learning community. Today, our network of providers engage in a comprehensive model that includes providing or coordinating services in what we call our 5 core program areas. So that's medical, dental, behavioral health, health education, and youth development. Additionally, all of our school health center providers are supported to go beyond the co-location of services. They establish trusting and collaborative relationships with the students and the school faculty. They all attend the coordination of service team or COST, participate in school assemblies, health fairs, as well as host workshops for students and their families. So AC Health contracts with 10 lead agencies to provide school health center services. 5 of them are FQHCs or federally qualified health centers, and 5 of them are behavioral health community-based organizations. FQHCs, there are safety net providers within our communities. They provide services to the most underserved communities, our Medi-Cal beneficiaries, and those that are uninsured. Everyone here is most likely familiar and partners with community-based organizations, but I added the qualifier of behavioral health for clarity, as our 5 other lead agencies all focus on mental health. They do not have the licenses to be able to provide medical or dental services, and so they must subcontract with either a federally qualified health center or a similar healthcare provider to provide those medical and dental. So those 10 lead agencies oversee the 28 school health centers countywide that are providing services in 8 different school districts. School health centers, as Kate shared, are a part of a place-based strategy to increase access to health services in those schools and neighborhoods that are most in need. The locations were selected to support the schools with the highest concentration of free and reduced lunch, a proxy for students who have Medi-Cal. Here are pics from 3 different school health centers in Alameda County. Throughout my years working in school health, I've hosted so many walkthroughs of school health centers, and there is always at least one person who pokes their head inside a dental or a medical exam room and says, "Hey, that looks just like my doctor's office." And that's because it is. These are actual satellite medical sites that are on school campuses. Earlier, I talked about the 5 core program areas. I love this slide as it shows the health services that we provide, the description of those services, and the qualified staff that are required to provide those services. You can see that school health centers operate as a multidisciplinary team of professionals working in collaboration to serve children and youth. As this model might be new to some, I'm going to highlight what we mean when we say medical and dental. So medical services are referring to visits such as the administration of vaccines, sports physicals, reproductive health, the diagnosis and treatment of illness, and basic laboratory testing. And for dental services, cleanings, x-rays, and fillings. So over the next few slides, I'm going to talk a little bit about data and evaluation. It's worth noting that all of our contracted partners are also required to participate in our countywide evaluation of school health centers. So Healthy Schools and Communities partners with UCSF's School Health Services Research Team to support the evaluation of our school health center program. The data collection has varied over the last 30 years, but it is exciting to share that as of last year, UCSF is obtaining de-identified aggregate data from the electronic health records from each of our partners. It's taken a lot of effort and coordination to get here, and it means that UCSF is receiving data from 7 different electronic health records that they then need to analyze and report on. But we are super thankful if any of you have had to do double data entry. We've had eliminated that for all of our partners, and we know that we're producing the most accurate data as it's associated with the medical record of our students. Additionally, over the years, to boast about the team, they have produced a number of peer-reviewed publications on the impacts of school health centers, often using Alameda County Health as a model. And for those of you, the COEs that are familiar with the Department of Education's work on Project Calwell, this is the same external evaluator team that worked on that. As we've been partnering with UCSF for so many years, we are able to produce this slide that shows the longitudinal impact of school health centers over the last 15 plus years, dating back to when there were only 8 school health centers countywide. The top line, it might be a little hard to see, the top line is our visits, around 63,000 visits. And the bottom line is the clients served, around 16,000 students served. I know this group is all familiar with CHICS. We partner with the local LEAs to have a school health center specific module added to the CHICS. Utilizing data from that module, we have been able to demonstrate that school health center users are more likely to obtain care in both reproductive health and counseling when needed in comparison to those students that do not use school health centers. And lastly, obviously, you want to be able to talk about impact for the students. This slide highlights the response to our anonymous client survey that is offered to all school health center clients every spring. For this year in 23-24, we had over 2,000 students respond, and nearly all clients agreed or strongly agreed that school health centers help them to learn how to take better care of their health and to meet many of their health needs. So now I'm going to speak a little bit about school health center financing. So this slide represents in general the current financing for our Alameda County School Health Center lead agencies. The largest percent of their revenue is through third-party billing. And before I kind of go into this, I do want to highlight that what I'm about to share may be different from county to county. And so this is how these work in Alameda County. So there are 3 main billing sources. Without overcomplicating things, for the most part, FQHCs bill the managed care plan for their services. FQHCs also can bill Family Pact for reproductive health services for individuals who are uninsured or who do not qualify for Medi-Cal. In Alameda County, specialty mental health services are separate and are funded and managed by our county behavioral health department. So both FQHCs and behavioral health community-based organizations can contract with the county behavioral health department to be a specialty mental health services provider and bill for their services. School health centers also rely heavily on various grants and contracts to fund services and personnel. Some of the larger ones that you all might be familiar with are Title X for reproductive health and SAMHSA for behavioral health. And lastly, I had mentioned funding earlier as a way that AC Health supports the school health centers. We provide what we call a base allocation to help offset the non-reimbursable costs that's associated with operating a school health center. We braid 3 main funding sources to create this base allocation. The first is Measure A, which is a half-cent county sales tax for essential care services for indigent, low-income, and uninsured children, adults, and seniors. Tobacco Masters Settlement Funds, or TMSF, from the state settlement with the tobacco companies. And lastly, the Oakland Unified School District has been designating funding to support school health centers since the late 2000s. In 2010, they were awarded a Kaiser grant, and each year they have been awarded, they have contributed funds towards the OUSD school health centers. So for this slide, I just wanted to show a deeper breakdown of what the base allocation is. So Alameda County Health, we provide around 3.3 million annually. Again, this did not happen overnight. A reminder that the School Health Center Coalition started in 1996, and it has taken so much advocacy and efforts to get to this point, and it requires a lot to be able to maintain it. The blending and braiding of funding has allowed school health centers to thrive and grow from 6 to 28 sites, but it has not been without its hurdles. Just last fiscal year, the Kaiser OUSD funding that I shared about was actually unexpectedly cut in half. So this 15% represents the change, as in prior years, it was around 30% of the allocation. And we as AC Health have had to navigate to be able to maintain that same amount that we provide our school health centers. And so as evidenced by the base allocation, AC Health is heavily invested in the impact and the sustainability of our school health centers. We recognize that there are a number of upcoming changes impacting the landscape of school and health, all taking shape around the same time. And to better understand them, we contracted with West Ed to help us explore the statewide reforms with our agency partners starting in February of 2024. Our goals are listed up here, and as Patrick shared, this project concluded in a 50-page report and a slide deck, and I will go over some of the main points over the next few slides. But I want to note that we recognize that successful understanding and implementation of these reforms would not occur in isolation. And so throughout this project, when we did our deep dive sessions, we had invited all 8 of our LEA partners to be a part of the process, as well as ACOE. Again, from the earlier slide, you may have seen the 2 major reforms that we discussed were CalAIM, which is California Advancing and Innovating Medi-Cal, and CYBHI. So CalAIM is a massive multi-year initiative that impacted both our federally qualified health centers and our behavioral health community-based organizations. It really focused on providing a more equitable, coordinated, and person-centered care that not only looked at the health needs of individuals, but also the social determinants of health. And CYBHI really integrated 13 different work streams to transform how California supports the behavioral health needs of children, youth, and families. This included services at school, services online, and support services such as this community practice through the capacity grant. And so in looking at the opportunities for school health centers in CalAIM, we focused on enhanced care management. And I believe you all had a presentation about ECM last year or earlier this year within this group. So ECM is intended for the highest risk and highest cost Medi-Cal beneficiaries with the most complex medical and social needs. These individuals often have multiple providers across various systems. And so that ECM provider really acted like the glue who would work with all the providers to add an additional layer of support and coordination. So the opportunity that we saw for our school health centers is that many of our school health center lead agencies were enrolled as enhanced care providers, but very few of them, in fact, at that time when we first started our deep dive sessions, only one of them actually had an ECM service provider located at a school health center. And then the 2 areas we covered within CYBHI were the certified wellness coach and the fee schedule. And so for school health centers, wellness coaches really appeared to provide a pathway to expand services and qualified staff. The scope aligned with the services offered by our school health center health education staff and the case managers. And these positions are often underfunded as they are non-revenue generating. The fee schedule provides many opportunities, but for our school health center partners who are already eligible to provide and be reimbursed for behavioral health services, there were two opportunities that really stood out. The first was the listed services in the fee schedule that are not currently reimbursable for our FQHC and our behavioral health community-based organizations. And second is, and before I jump in, I want to be a reminder that outside of any special grants or funding, FQHCs and behavioral health community-based organizations that we partner with primarily serve Medi-Cal beneficiaries or the uninsured. However, as these school health centers are really that safe space where students come to be able to connect with healthcare providers, there are a number of drop-ins that happen for students that are privately insured. And so the inclusion of private insurance within the fee schedule really provided our school health centers with the opportunity to now be reimbursed for those services. Granted, most of the school that the school health centers are in, the free and reduced lunch rates are quite high. So it's only a fraction of the population, but it still happens quite often that we have private insurance students seeking services at the school health center. And at the end of the project, these were some of the key findings that I want to be able to highlight for you all. So through the discussions, we identified that the school health center clients, there are a number of school health center clients that fit the criteria for ECM. And so we really encouraged our agencies to explore staffing models that would include ECM providers at the school health centers. As a result of this conversation and following the deep dives, most of our behavioral health community-based organizations now actually have some allocated hours for their ECM staff at the school health centers. Secondly, so behavioral health staffing models for FQHCs and behavioral health CBOs are really based off of their third-party billing, like I shared. And so the fee schedule offers the opportunity to blend funding to support those positions and increase sustainability. But the fee schedule alone would not solely sustain a position, is what we found out. And lastly, once the fee schedule was updated to include the eligible services for the certified wellness coach, we identified two services that are not currently billing eligible for our school health center partners. And that was the group skills training and the case management. And so for our school health center partners who have the opportunity to become a part of the fee schedule, they would be able to bill for those services that they are currently providing. All right, and now I'm going to hand it back over to Kate.
Thank you so much, Cal. So we're gonna basically talk a little bit, wrap up by talking about our developing partnership with Alameda County Office of Education. We've obviously been in partnership with Alameda County Office of Ed for a while, but because of all of these reforms and because of the positioning of offices of education within this health and wellness work in a sort of increasingly centralized way, this is even more important. So one of the things that we've been able to do together over the course of the last year and a half is develop this Alameda County School Health Steering Committee. You can go ahead and go to the next slide, Cal. And really the purpose of this committee is up here. So it's to implement one integrated school health system, keeping equity at the center, again, lifting up populations who are often, underserved, and then doing this cross-sector collaboration. So you can see some of the organizations underneath that are participating in the School Health Services Steering Committee. And it also, I noticed, doesn't have any of the school district logos, but we also have invited a number of school district leaders to participate so that we're sort of all at the table having these conversations. And yeah, I think that's what I will say about that. That's been meeting for about a year and a half, co-led by our director, Lisa Erickson, and Alameda County Office of Education staff. So that's been a great partnership. And basically the structure of the committee is, as I mentioned, the steering committee, which is about, I would say about 20 folks at this point, meeting on a monthly basis. We're actually switching this year to meeting on a quarterly basis for longer meetings. And then the School Health Services Advisory Committee was developed last year, and that is made up of about 50% students, youth, 25% caregivers and parents, and then 25% community providers, and they meet on a regular basis. And we're still building the connection between the steering committee and the advisory committee. I'm really making sure it's relevant and as interactive as possible, and also recruiting for the advisory committee to have even more students who are, most impacted by these services. So that's an area that we continue to work on, again, co-hosted by ACOE and our staff here at Healthy Schools and Communities. This year, we're really focusing in on 3 work groups. We're kind of, as you say, like getting into the weeds of really doing this work. Like, what does this really look like? So we're focusing 3 work groups on the 3 first areas. So workforce development, school-based behavioral health, workforce development. That's a partnership between somebody on our team who's run internship programs and does all kind of, training and support across the county, and staff from ACOE, their PATHS program on their school-based behavioral health. Sort of like they're building out that part of their system as well. So they're partnering recruiting right now from workforce education and training, CBOs, a number of places to really, again, look at what can that look like. We really know that our workforce needs to be supported and built. Service delivery, sort of that's the referral system. So whether that's coordination of services teams, like once the students referred, what's this process look like? How can we make it more consistent? We want to get, again, all the systems partners at the table to have these conversations. So that's going to be co-led by somebody from our shop and Alameda Alliance, who is, helping to pull this work together in Alameda County. And then sustainability. So that will be partnered, that will be ACOE and our Alameda County Behavioral Health Department led, looking at some of that intersection between CalAIM and the fee schedule. So we'll look forward to continuing with those work groups in 25, 26 and really figuring out how to do all of this work together. I think that is it for us. And just really want to thank all of you for listening and excited to be in partnership and answer questions. And I will hand it back over to Liz.
Thanks so much, Kate and Kale. Appreciate the wonderful presentation. As somebody who previously worked at a federally qualified health center, it's really fun to see all the different ways that offices of education and LEAs partner with FQHCs. And so I think there's a lot to think about as it relates to our systems of care and how we apply this work to our local context.
Great. And if folks need to jump into a room while we're going to question and answers, that's fine as well. Some folks might be coming back and forth between the rooms depending on their experience and what they'd like to spend their learning time on. So thank you so much for hanging in on part of the questions and answers. It's fabulous. Thank you, Kate and Kale, for providing such great information. Oh my God, so inspiring to see all your efforts since 1996, I think you said. And that's amazing. I mean, yeah, it takes a lot, but I think your illustration is what capacity building is in Alameda County and just staying focused. So again, thank you so much. If folks have a question they'd like to go ahead and ask, feel free to raise your hand and we can take turns coming off mute if that works for folks. And or you can also put your question in the chat, either one, and we can go ahead and read those and for you and ask the question as well. Well, I'm thinking some of the questions that come to my mind, Kate and Kale, as you're collaborating and looking at your funding, it looks like you've been able to, kind of fund it from multiple sources. And you talked a little bit about the funding landscape changing this last year because of, I think it was Oakland, Alameda County, some of that funding shifted or something. Can you speak a little bit about some of the strategies as you anticipate and preparing for that? What are some of the things that are coming up as you're just, I know you have to respond in real time, but what are some of the strategies that you're using to look at the landscape ahead of you to inform kind of budgetary planning?
Do you want me to start, or do you want to start, Kim?
You can start with this one. Yeah.
Okay, one of the things that we were able to do, sort of Kale spoke about the paper and the work that WestEd did in concert with the school districts and also the lead agencies, both the FQHCs and the behavioral health focused CBOs. As that sort of came to a close, we had the opportunity to apply for, probably a lot of you are aware of the MHSSA funds, or now BHSSA funds. We applied for the sustainability grant, and we were able to start another contract up with WestEd that was really focused on working with districts and CBOs related to school-based behavioral health sustainability. So we're partnering ACOE, ourselves, and WestEd to continue to look at what our CBOs might be able to leverage. The school health center work is a piece of that, but the behavioral health work in particular that our school health centers do should really be able to leverage that, is our hope. So that's one area, just to continue to be in conversations. I think the school health services steering committee that I talked about, where we have people from the different sectors trying to sort of get in there and take things apart and figure out, like, when you have the kid in front of you, how are you going to make this work? In addition, in terms of just generating dollars, our county just passed another sales tax, Measure C, that was sort of held up for a few years, but now is moving forward. And so we are actually hoping to be able to use some of those funds to make up some of the difference with that Kaiser loss. So it's sort of like, I think really the name of the game, and Kale, you can talk more specifically about school health center, is just that responsiveness and the partnership, I think. And also we're lucky to have a county that's dedicated to this work, I will say that, and it's big enough so that it can generate the dollars to manifest it.
Well, that's huge. That's kind of the economy of size that you're benefiting from. However, smaller counties has less volume, so I think that shouldn't be a barrier. I'm thinking about the tax. What's the genesis of that? Has that been in place for many years? Is that something that's really kind of grown in the last decade or shorter period of time?
The Measure A, so the Measure A sales tax, I can't sometimes joke that that's funded the better part of my career, honestly. I worked for a public health department, and then and doing sort of connections between public health, a smaller one, between public health and the school district, and had several public health nurses who were sort of embedded into the school. So that's been all that to say, sorry, enough about me. I think that that sales tax, I think, has been in place for about 15 years. Kel, do you know?
2004 is when it, yeah.
Okay, right, so about 20 years. So, and then this new one, I can pull the language up on that, but honestly, I hadn't even paid that close of attention to it because it passed a few years ago and then was sort of held up in legal land until our director's been heavily involved in moving that forward with our board of supervisors. So I think, is that answering your question, David?
Yeah, that's so helpful.
Yeah.
It generates more, but I'm curious, Kale, what are your thoughts in that same space?
Yeah, so sustainability has been kind of something that's been coming up with our school health centers since coming out of the pandemic. And so one of the things that I've taken on in my role is like really trying to look out for grant opportunities that are coming down the pipeline and then getting it out to the learning community, specifically to the directors or the FQHC staff who are applying and looking for funds. So there was an ACEs, the Adverse Child Experiences screening. And so getting that out, and we had one of our providers who was awarded that contract and was able to expand their behavioral health services. CYBHI, obviously, like I had shared and many of you know, had 13 different funding sources that even trickled down to even more opportunities. And we had folks who applied for different grants in that realm. Specific populations. Something really amazing we have is an LGBTQ drop-in center that one of our school health centers received funding for. And so they gathered up all the funds to be able to open up this drop-in center. And they actually have 2 health centers. And so then they were able to find other local grants to offset the costs and open it up in a smaller scale with less funding, but still be able to have that opportunity at the other site that they have. And so there's the major funding sources through third-party billing, and those are kind of set based on how much clientele you're seeing and the student population. But then it's really a juggle to try to find alternative ways to be able to maintain and increase their sustainability financially.
Yeah, and that's really helpful looking at trying to see what are the multiple pathways of funding. I think your county measure to increase some of the tax revenue in the local community to serve the community is really powerful. I think you mentioned at some point 2 steering committees. How does that play out in relationship with Alameda County Office of Ed or other larger districts? How do they play an active role in the steering committee with you?
Yeah, the school health services. So there have been a number of steering committees and leadership. There's a lot of different leadership structures, I would say. This is a relatively new partnership between Alameda County Health and Alameda County Office of Education. That doesn't mean there hasn't been longstanding partnerships in other arenas, but this level, not just like our agency director and the superintendent of schools, but then also having people like that's the executive leadership team. They're just layers of leadership teams. This one, I think, with the School Health Services Committee gets people from all the different sectors. The hope is we had something called the Interagency Children's Policy Council a while ago, which was not dissimilar. They rise in, at different moments, but the hope is that this space, given all of these shifts, I think like every system is in massive flux right now. It was even before, before the federal government shifts. So I think that having those spaces is that much more important to figure out how we can leverage all these dollars. Because I think so often there's all of this parallel planning that happens, and the more we can do concurrent, which is really hard to do, but the more we can do that, the better off we'll be, I think. And so that committee is in service of that work. And some of these other partnerships like the sustainability work with West Ed, that's so that we're working in concert and saying the same things to our districts and our CBO partners and our FQHCs, whether we're from the Office of Education or our county health department, so there's a lot of translation that needs to happen. And if we can support each other in doing that, that's a big piece of the work, I think.
Yeah, absolutely. And that's part of the work we're really trying to support to building capacity.
Yeah.
Building how do we work on each other's, steering groups or build that together to nurture those relationships over time.
Yeah.
That's great. So I'll pause there to folks in our breakout group, questions and answers. Have any questions for Kale and or for Kate or comments related to the topics? Feel free to raise your hand or you can put it in the chat, whatever feels right for you. All right. Well, then I guess I'll go to my next question. This is all about David. I like it. Just kidding. Thinking about that space you have in your healthcare centers in schools, and I know your target audience tend to be students that are underinsured or not insured or Medi-Cal eligible. How does that work in tandem with the schools when a student comes in that does have private insurance, and now that partnering that space with the CYBHI? Has there been some lessons learned on how to provide that open doorway as a way to serve youth? And then now with CYBHI being another way to partner with maybe some of those tier 2 level interventions that may not be as qualified or the same student need. Do you have any examples of how that's kind of developing now as this new relationship with CYBHI?
Go ahead, Kale, because I was going to leave it to you in terms of what happens when a student comes in with private insurance. I think the CYBHI is another layer we're still really early in that, to be honest. Like, I don't think we even know yet what that's going to look like. I think that's part of what we're exploring with the partnership. But I think in terms of what happens when a student comes in with different insurance, Kale, you're in a better position to answer.
Students come in, they kind of have the school health centers are seen as like a safe space on campus. One thing I wanted to highlight is that what's different between the model that we have in Alameda County versus other school health centers across the state is that youth development and health education are really core to what our service providers are encouraged and supported to do, and a part of the contract that we hold with them. Because there are other FQHCs that are able to be sustainable because we really want them to be embedded in the campus. We want them to attend cost. We want them to be able to do presentations, to work with the school faculty, to hold these youth development empowerment groups. That relationship is a little bit unique in how they do that. And so because of that, because there's all these different reasons that a student might come into a school health center, then there is that opportunity for a student who's like, oh, I'm part of the youth development team. Now I have a crisis. Their person who they're most connected to might be the health educator at the school health center. So they do drop in. School health centers will provide support, obviously, if a student comes in crises. And then that's really the opportunity when they find out, if they discover that that student has private insurance, to really be able to connect them to someone who is on that private insurance panel. And so in the cost format, though, when all the different providers and in Alameda County, and in particular, the sites where our school health center is at, we're talking like some sites are like over 90% free and reduced lunch. So there is not only school health centers representing behavioral health support, but those specialty mental health providers that I talked about, that's managed by our behavioral health partners at AC Health. There might be 2 organizations that also have therapists, though, there. And so the lead cost facilitator, is really looking at like, oh, who has Medi-Cal, who are the resources and the folks that we can try to connect students to make sure that they're going to get the services they need.
Yeah, that's great. I would see that as probably depending on the student proportionality where they would fall, kind of to your point, if they're 90% free and reduced and Medi-Cal eligible. But it's still kind of like normalizing it, right? How do you normalize the access point for youth to come into spaces in school and or healthcare to say, hey, I need help, right? We want them to be like, great, and kind of that carry them to that next space. And probably through practice, through design, we'll find better ways to, blend and braid that. And to what degree would there be MOUs between obviously establishing those agencies that then claims could be submitted and or through CYBHI to be appropriate, to kind of subsidize the cost of that delivery model for that, let's say, behavioral health person or, the FQHC provider, right? Be able to get reimbursed at that fair amount. Yeah, that's great.
One other thing that's interesting, and I'm wondering if other offices of education, well, I know many of you are, is sort of like the whole wellness center. There's been more and more sort of blossoming of the wellness set, and everybody calls it, people call things different things, like working with the California School-Based Health Alliance. They talk about how in Southern California, the school-based, what we call school health centers are called wellness centers. So the distinction we make is sort of the wellness centers, which more and more of our districts have and sites have, because they're not as expensive to build. They're not like there's a flexibility that they enable also in terms of drop-in services that are a bit different, obviously, from school health centers. They're not providing, in our definition, they're not providing medical services. But I think thinking about how they work in concert is really important, and integrating them in the sites where there is both a school-based health center, which is operated, by sort of outside providers, and then a wellness center, which might be staffed by school staff, in addition to, sort of like, but really thinking about that integration is something that we're also co-leading with Alameda County Office of Education, a learning community related to wellness centers. And that includes people who work at a district level, in addition to folks who are running wellness centers at sites. So we just did sort of an analysis of like what was happening across the county with ACOE, and then it really got lifted up that was a space that people wanted to learn from each other. But thinking about this integration and what purpose everyone's serving, and how it's really having students at the center, what are they asking for, what are they needing, I think it adds to that picture. But I'm wondering if other counties are thinking about that and how that's going in that way.
Yeah, that's a great question. Folks want to lean in and provide perspective?
I'm sorry, I had to leave for a little bit, but I just got back. I'm amazed of how many health centers that you guys have there. It's crazy. So when the first couple, I'm sorry, did you guys already go over this part?
Oh, it's perfect. Welcome back, Rhonda. We're so glad you're here.
So basically you showed 35,000 students. Is that how many students are actually in Alameda school district? Or is that how many you saw?
The 35,000 is the and let me make sure I'm saying this right. Yes, the 35,000 is the number of students who have access to the school health center based on the school health center's primary schools. So our 28 school health centers, they're either co-located on a school campus, and that's the majority of them. And then there are a few school health centers that are like right across the street or literally on the other side of a fence. And there might be a middle school or the high school, which is their primary school where they're going and doing their health education and they do reproductive sexual health like fairs. But then there might be an elementary school that's right there too, where students can also access. So there are a number of our school health centers that also have community entrances, really in an effort to be able to support a whole family and be that hub within that region for multiple sites.
So
But
do you guys cross different school districts then? Is that what am I hearing?
we're in 8 different school districts.
Oh, wow. Because I know Oakland's huge, right? Do you have Oakland? Is that right?
Six-
Okay.
That's where
16
the
of the
bulk of
28.
yeah, that's where 28 of the school health centers are in Oakland.
Oh,
No, we're
I'm
talking
kind
about-
of like off a little bit because
Yeah, talking about 19, I think it's 19 school districts here. We're in 8 of them. That's when we sort of talked about where we are is based on sort of income and, you know, health and education outcomes and those sorts of things. So we're talking about multiple school districts. And I just looked it up. There's about 220,000 students across Alameda County. I was like, how many are there? So that's like the total number of probably, I'm guessing TK or K through 12 students here. So that's a percentage of all of those students. There's 150. How many schools are there in Oakland? I think in Oakland there's 130 schools. So we're a big
220,000 students and that's how many actual, yeah. But the campuses they're on, there's 32,000.
Have access. Yeah.
That's right.
That's great. That's like, what is it, like 1/4 of the students are like right next to it?
15% maybe.
15?
Yeah.
Yeah, fantastic.
And that really is, you start to think about it that way, just the impact. And also, as you were saying too earlier, Kate, you know, looking at triaging what's available. So, you know, looking at making sure like tier 1, tier 2 level support maybe is served through the wellness center with lower level support because it's more broad level. And then if it gets to a higher level of medical necessity or greater level of crisis that would qualify for the FQHC, then that partnership is very visible. Thinking that there's probably other underserved areas within Alameda County. Are there plans or ideas to develop other partnerships with some of the other districts that may also have that need?
I mean, 100% honest, I don't think we're in a position to be building new health centers at this point. And part of that is because of the funding even that the schools have. I mean, to build you're building not a hospital, but like you saw the pictures of like
full medical service.
Like it's like medical operatories, dental, you know. So I think what we're trying to do really now is focus on sustaining and improving and honing in. And partnerships, yes. So I don't always partnerships, linkages with clinics. I think like the more, even with CYBHI, the more people know with parent outreach workers, the more people know how to link folks with supports and services. That's not going away. That's a core function of, you know, our work and our service. But building new health centers at this point, I'm not seeing that given the funding predicament that our county health department and our schools and everyone is in at this moment, to be 100% honest and transparent.
Well, staffing alone, I'm assuming is kind of rough. You guys must have a huge amount of department that just takes care of that, correct? Or, do you have a large amount of staffing?
We don't staff the school health centers. They're staffed by each of the lead agencies. So
Oh,
we
nice.
have 10 different lead agencies who are operating the school health centers.
But just your staff alone at the county health, is it just you two? Or are you guys like huge?
Our health department is huge.
Oh.
Our Alameda County, like our little department, Healthy Schools and Communities, is about 45 staff.
Okay, that's what I was asking.
Yeah, but then our behavioral health department is hundreds of staff. and
Yeah.
Public health department is even bigger than that, and environmental health is little, and we have, so there's many different departments, but our department is 45, and we do we didn't do that introduction because I don't know how many people care, but like we do a combination of getting money out into like like the MHSA PEI funds we get to districts and partners, the measuring, so we get money out. The school health centers are one of the ways that we get money out into the communities, the CBOs and the districts. We also have staff who are situated to support school districts at the leadership level and some staff at sites. We also operate, probably most of our staff we operate Reach Ashland Youth Center, which is in one of our unincorporated communities in Alameda County, and serve is an amazing space that was sort of like the idea developed by youth in the community, and so we operate that's a number of our staff too. So that's kind of how some community health workers, we sort of like dabble in all the areas. Yeah, and we've developed a language we call like coach-sulting, which is sort of some coaching and consulting related to this work. And the money stuff is now something we're trying to build our capacity to support alongside ACOE, because it's, in some ways we've been doing it for years, and in other ways everything's shifting all the time and it's hard to keep up. So yeah.
And something
Sorry, I was just wondering. Oh, go ahead. I was just kind of wondering because it sounds like you guys have a lot on your plates, and it just seemed like you would have a huge amount of staffing to help with all the different things you're into. Okay, thank you.
One way we do, I will say one way that we really leverage the partnerships and even the contracts is with learning community, sort of like this community of practice. Like Kale hosts a learning community for the districts that host school health centers, and also all the coordinators of the school health centers on a monthly basis. So last month we talked about sustainability. So, and we have one of those for the wellness centers, like I mentioned before, for different groupings of sort of job alike that are across the county, because we know people can be so isolated in their work, and that's how cost, kind of our coordination of services teamwork, that's sort of where that developed, was like lifting up best practices from the different districts. So that's a real way to bring people together to, again, like this, to sort of share best practices and ideas, like what are you doing about this? So, and that's one of the things the COEs also, I know, do well.
One piece I wanted to touch on, because it was asked about new school health centers popping up in Alameda County. And we do not have any new school health centers popping up in Alameda County, but across the state, there are a number of school health centers that are opening. As it was shared, like Alameda County stand on the shoulder of giants. Like we were pioneers in a lot of ways for school health centers popping up. I'm the local affiliate, Alameda County representative for the California School Health Alliance, and I flew down to Inland Empire last year for their in-person meeting, and we got to tour like a brand new health center that just got built. And there's a lot of different involvement. We primarily work with the LEAs, but in other places it's the COE. Like, there's a saying, like, you go into one school health center, you've went into one school health centers. They're very different in so many different ways. We have some that have these large, beautiful buildings that were just built as a part of like there's like one that's connected to a brand new basketball arena that was just built on a high school. And then we have others that are working out of portables, that started back when this whole movement happened in Alameda County. So.
Oh, that's great. Oh, that's wonderful. Yeah, it's really nice to see when we can share those expertise. So for you, Kale, to be able to go down and be able to provide ideas and consult and witness. And I mean, I think that's just kind of building more of that solidarity and then making it more visible. we had one of our county office colleagues, and I don't know if they're on this group right now. Del Norte County invested with some of the capacity grant dollars to do a mobile van. They're a rural county, and so then they're taking those services to some of their smaller parts of the county and providing therapy and dental and a whole bunch of variety of things. So that's another, way. Do you guys coordinate some of those level services for maybe areas that you don't have a clinic, or maybe behavioral health has some of that within Alameda County?
So that's a great question. So to clarify, so as the county health department, we don't oversee all the school health centers that are in Alameda County. We contract with the majority of them. So there are school health centers that are in Alameda County who are not contracted, paid, not paid, is incorrect word, funded school health centers that are operating in other school districts. There's even one that's at a junior college that one of our FQHC partners, they oversee that school health center, but it's not a part of the network that we're supporting, that are part of the learning community, a part of the school evaluation. So it is those ones as a county health department, we have to RFP and put all these different things and the funding. So it's not to say that we support we're not the entirety of all school health centers.
I'm here in Madera, and I was with the Madera Behavioral Health, and they were talking, I think a few months ago, about how there was this program where a crisis, so like if there's a crisis up in our mountains or, like far away, they take a crisis team up there and help the students out and all that. And they were talking about, I believe it was pretty successful, but then all of a sudden the funding got cut. I don't know if you guys had heard about that, but anyways, they're trying to figure out how to get the funding going again. But that crisis situation, in the smaller areas is just so important, especially, you have a student that's suicidal and can't get them down here. You just send somebody up. So I don't know. I found that kind of interesting.
Yeah, no, that's great. There's been a lot of work around sort of revamping the way mental health crisis support is offered here, right? I think historically it's always linked with law enforcement, and there's been a lot of work here to de-link it or unlink it. And so we actually have some innovative, many of them coming out of the behavioral health department, but connections. So like, instead of dialing 911, you're dialing another number, so I think that innovation and trying to figure out how to make that work differently is huge and important, and is happening in a lot of different places. That's great to hear it's happened there. I'm sorry about the funding cuts. It's like, that's the hard thing to like do something for a long, that's why the blending and braiding, right? It's like, we have to keep doing that, because you don't want one funding source disappearing to like mess up your whole, but it's a whole other skill set from certainly what I had when I, was in social work school. It's like, so, it's good stuff.
Yeah, it's really good. Oh, Rhonda, go ahead.
Oh, I was just going to say, what, last year, like you were in your schooling last year, Kate, like that's funny, but then I realized now. I know, well, and sending out the police on that whole concept of if you have somebody suicidal, or in the area I'm in or around, I'm sure everywhere, they're not answering the doors for the police officers because they think it's ICE. So they're literally, even truant officers need to be changing their whole demeanor and their clothing. And we had this whole discussion about that, just to not be out like that. So, which I found interesting, but I don't know.
Definitely don't want to send the wrong message or ignite fear and anxiety around just responding to students and families' needs. For sure. Yeah, it's a very nuanced time. And how do we provide that support in a way that's more available for folks?
One of the things that we heard at our learning community last month was just the numbers of folks, more in the community clinics, but also in the school clinics, is just drastically declining, because people are afraid. And so that's, you know, that will impact funding too, right? You can't bill for people who aren't there because they're afraid to get services. So that's a dynamic that we're, you know, trying to, again, collaborate and work together on. Is there more money here if there's less money here? Because those cycles are always present, and now more than ever it feels.
Yeah, absolutely. And important too, I think, back to your data slides, I think, Kale, you provided a really nice data slide that showed the arc of services. It also showed the drop off of service and drop-ins due to COVID-19, and then the return as students gained access to getting out socially. So we're in the same era. We don't have a pandemic that's forcing people into not receiving services. We have a social culture climate that's creating the conditions for the folks to not reach out for services. So I think that longitudinal data may play a role in terms of advocacy at the county level, at the state level, that we maintain higher levels of funding, because it's not like there's less need for behavior, mental health, medical services. There's only going to be a repressed repressed level of access for those, which will increase a greater level of need on the outside when things kind of level off or just change in general. So I think it's important to maintain that data and use that as a way to kind of, as the canary in the coal mine, to put that out there for folks.
And potentially the schools potentially could be safer than clinics in schools could feel safer than clinics in the community, right? Like that would be a goal, which is something we're trying to pay attention to, which makes this work all the more.
Yeah.
Yeah.
That where kids are at school 6+ hours a day, increased extended outside of classroom learning, after school learning opportunities, weekend, which makes me think, are your programs also available for youth and families on the Saturdays and Sundays in these centers, or are they tied to traditional business hours?
They're tied to school hours, not traditional business hours. I hesitated for a second because that's one of the pieces that they really, these larger FQHCs have a number of different sites. They'll obviously have their main clinic. And so they really try to select those staff who really want to be working at a youth empowered place. And so they might have different hours than the folks who are at the main clinic, because they want to be able to mirror when students are there and available to access. But to answer your first part, no, they're not open on the weekends. That's referral to the main clinic.
And then how does it work during the summer sessions? Are they closed during the summer?
Most of the school health centers remain open. I could get into nitty gritty. There are like a few school sites that maybe like have completely closed off campus because they're up on a hill. Like we have this school skyline that's like, very, very, difficult to get to, and none of the students would be able to access. But for the most part, they might reduce some of their hours or the days, but our school health centers remain open during the summer.
That's great. Yeah, it's great to have this discussion. I really appreciate your information. There's so much to think about in this space, and I think as we can lift up, your lessons learned. One is how the partnership, how the capacity building, cross-agency partnerships, your partnership with county, lifting up a measure and additional tax funds and some additional things. I think those are huge things. We're coming to the end of our session for Q&A, so I'm not sure if folks would want to add into that. Maybe Rhonda, you and I, and some other folks would want to add in the chat any key takeaways from the discussion, so our colleagues can kind of get some of that information, just real high level. I'll put a couple things in. But again, really appreciate your time, Kate and Kale, for providing us. I think the model takeaway that I think about in another large county is, how do we do some cross-county partnerships for measures and tax investments? Because if people are spending their money in our county, then that's a great way to put those tax dollars to support the youth in our county. And it's an easy nexus to make, especially if it's around purchasing power. And I think that way it's more like you purchase, then you're investing. So I think that was a huge takeaway for me today.
And it doesn't start with something where it ended. It started very, like, I think it's like there's so many around it, but I think, so just I think that, I hope that's a takeaway too.
One of my takeaways is that it's possible. It's like you're showing us what's possible out there when we're a lot smaller and get people to think outside the box and start looking at different ways to do things. So thank you.
Thank you.
Well, other groups will be probably collapsing the breakout rooms in each session. They'll be joining us. So we'll go ahead and make room for our colleagues to return to the room.
All right, welcome back. Welcome back. I hope everybody had some awesome peer learning. If you are feeling called to it, would love to see some reflections that are coming from your peer learning session. Feel free to pop them in the Zoom chat. And to kick us off, I heard that Heather and Leslie were interested in sharing some key takeaways from the Work First room. Is that right, Heather and Leslie?
Sure. It's a good little preview to our presentation next month. Just so we were in workforce, and one of the trending topics was wellness coaches, and some people in our breakout were intrigued to learn that in San Diego we are starting to see principals, assistant principals, director of student support services at a district become certified wellness coaches, because as they're working with our team and our EHR vendor, they're realizing that everything they do all day with students is billable, but they don't have a PPS credential. So it's been a real smooth, easy process working with our teams to get them certified as wellness coaches. And so that's something we are lifting up in our county. It's kind of gaining traction, and we'll speak more next month about it.
Yeah, thanks, Heather. Really appreciate you sharing about some of the conversation that was in the workforce room. Would love to invite anybody else who had some life-changing moments in their breakout room, maybe, or just some ahas, some learnings. Anybody else want to share? Feel free to come off mute.
Is this for any of the breakout rooms?
That's right.
Okay, I volunteered, so I'll go for our fee schedule group 1. And we just had a lot of great questions. And one of the questions that came up, and it was good because I thought I imagined hearing something, you know, when you go to so many of these webinars and you're like, I thought I heard. Well, one of the things that came up was a question about NPI. Like some LEAs were considering having a specific NPI for the LEA BOP versus the fee schedule. And another person confirmed they heard something like that come up the past week or two as well. So we had some questions around it, and Mike Lombardo was in our group too and suggested that we do ask that question just to get in writing, because it seems like some others heard it early on in the process. So we know how things kind of evolve and change. And so we just want to circle back to that question about minor consent. So I think there's discussion about putting that on the community forum to see what everyone's doing. So I think that's an interesting one. And like I brought in the legal piece too. So like kind of district implementation process and guidelines, but also like where's the legal stance in that, whether an LEA can choose to exercise or not exercise minor consent. So there's that question. And I think I'm forgetting one more question that we're tackling. Oh, how are we working? What kind of strategies are we using to encourage the providers to participate in this documentation and billing process and submitting claims? And so we had some discussion about how if PPS, like school counselors are often a large group, like how can we leverage like Cask and Loretta to kind of present and valid and just kind of support that this is within the role of school counselors. And so I know Carissa has her wheels turning about how we can support that statewide. So if I missed anything in fee schedule group 1, please feel free to jump in.
Thanks, Mayu. That was great. I'm seeing some love in the chat for your summary, Mayu. So I think you did a wonderful job. And it's great what I heard from our group is there's so many meetings, so many different updates. It's really good to be in small spaces to process what that looks like for your local context and then be able to organize around next steps. So really appreciate that, Mayu. And we have a couple other rooms. We've got the partnerships with County Behavioral Health and FQHCs. We've got our small and rural county offices of ed and fee schedule number 2. Second fee schedule room. So we have a little bit of time. So if there's anybody from one of those groups that wants to share an aha, we welcome your voice in this space.
This is Rhonda. I wanted to talk about that MPI, and I'm sure we talked about it last time. I can't remember which meeting I was on, but I could have sworn a few years ago, LA Bob stated that the district should have only one NPI. So you might want to check either, I know DHCS, but you might want to check with, is it CMS, the federal government? Is that where you're getting NPIs? Yes. So just to make sure.
Thanks, Rhonda. We'll circle this into our office hours. And I think that team also said they would post in the online community to help us prep for that. So that is great. Appreciate you.
And one more thing. I really found that the presentation was awesome, that actually seeing so many clinics out there and how they did this, it actually shows you have possibilities, what you can do in your counties to at least get one. Let's start with that. So thank you.
Thanks, Rhonda. Appreciate you lifting that up. We are all starting somewhere, which is oftentimes very different places, and there's no wrong place to start. Caitlin said in the chat, in the small and rural breakout, Mike from Humboldt shared about an LEA that had great success collecting student information from parents during parent-teacher conferences. That's great to hear. Thanks, Mike. Any final reflections coming up from folks? You can share it in the chat. You can come off mute. We'll take one more if there's anyone else who's interested in sharing.
Liz, can I share?
You can, David. Yeah, you can.
I was hesitating. I thought it was a really fabulous presentation and the learning around the partnership with the county around their Measure A, I believe it was, and trying to develop some partnership around taxation, some local taxation to provide services. And that could be a really good long-term goal for every county to do a partnership and capacity building on how can they find ways to generate local purchasing taxation to drive local response to the youth in our counties. I think that's something that is a long-term goal, but that is specifically to capacity building is powerful. And another piece that kind of came up towards the end of our discussion is just that with the current climate that we're experiencing across our state, that youth are not seeking services due to fear of being in places of identifying for being just in the wrong spaces in the wrong places. And with that doesn't mean that their needs are not there. And we may see a reduction in delivery of service, but the importance to maintain longitudinal data collection to illustrate that these needs are not going away, that there's going to be a repression of delivery of service, similar to what we experienced with COVID-19. So the graph that Kale showed could be replicated to some degree, potential. So just as a way to remind us, something for us to consider is just longitudinal data to illustrate the true need of what our youth are needing.
Yeah. Thanks, David. Thanks for anchoring us also in this place and time we're in, and the context of what young people are facing, what families are facing at home and at school, and how that always connects to the work that we do with school-based mental health services. We can't talk about school-based mental health without talking about the other conditions that our communities are facing. All right. And then I'll just end. Patrick shared in the partnerships breakout, they talked about, is the juice worth the